Good afternoon. I'm Michael McGinnis, Executive Officer of the National Academy of Medicine and Executive Director of the National Academy of Medicine's Leadership Consortium. And it's a special privilege for me to welcome everyone and to thank everyone for joining in the important conversation that we're launching today. Special thanks, of course, to the co-chairs of the Learning Health System Strategy Group of the National Academy of Medicine, represented here today by Peter Margolis and Sean Dowdy. And also welcome to our extraordinary panel made up of members and participants in the NAM Leadership Consortium, which provides the home for national collaboration on the shared commitments. And those individuals will be introduced more formally later on, but they are Michael Howell of Google, Jonathan Perlin of the Joint Commission, Suzanne Miyamoto of the American Academy of Nursing, and Donna Cryer of the Global Liver Institute. Imagine a health system anchored on the goals of each person and family, drawing on the best available evidence and information every time for every person, adjusting seamlessly according to changing circumstances, and growing the system-wide knowledge and evidence base in real time with every experience. 2 decades ago, the National Academy of Medicine assessed the state of the science and practice of health and medicine, the trajectory of potential developments in digital health and artificial intelligence, and the resources available to the nation to reach every person with the right care. Resources that now amount to about $5 trillion. And the NAM set out the vision in the charter of its leadership consortium for a continuously learning health system, one in which science, informatics, evidence, and culture were aligned for the seamless development of information and its application seamlessly as new evidence in the care of every person served by the system. Today, the nation has arrived at the point at which that vision is technically achievable. But with the stunning developments that we read about every day and the newspaper, hear about on newscasts, the developments in just artificial intelligence itself has been remarkable. But we also have seen factors in play that have led to a fragmented delivery system with misdirected incentives and rewards. So this achievable vision can only be achieved if we rally attention, action, and resources around the common ground that the shared commitments represent and which represent the product of what we learn is required as a component, imperative, and expectation of a learning health system. And that's what we're here today to discuss. Next slide, please. Here is the list of the shared commitments that have been developed over the last 2 decades, building on the earlier experience of the then Institute of Medicine, now National Academy of Medicine, in drawing the nation's and the world's attention to the issue of patient safety and patient quality. Building on that firm foundation and enhancing it with the 2-decade work of the National Academy of Medicine in collaboration with many partners across the country, important organizational contributors in various domains. We have expanded the focus to deal not only with issues around health care, but also issues related to the health of the population as a whole, and bringing online new important elements related to transparency, accountability, security, and adaptiveness. So I'm going to take just a minute to read through these very specifically, and we'll refer back to the concepts throughout the course of the conversation today. And that is our shared commitments, ours meaning the stakeholders and patients and families throughout the nation, as a trust framework for health and healthcare, indicates that we are committed to and expect health and healthcare that is engaged, that is, gives primacy to understanding, caring, and acting on people's goals, that is safe, deploys verified protocols to safeguard against risk from unintended harm, effective, applies continuously updated evidence to target goal achievement, equitable, advances parity and individual opportunity to reach their full health potential, efficient, delivers optimal outcomes and affordability for accessible resources. Accessible, provides timely, convenient, interoperable, and affordable services. Accountable, identifies clear responsibilities, measures that matter, and reliable feedback. Transparent, displays full clarity and sharing in activities, processes, and results, and reports. Secure, that is, embeds safeguards in access, sharing, and use of data and digital AI health tools. And adaptive, the learning element, centers continuous learning and improvement in organizational practices. These are fundamental concepts, commitments that ought to be expected by every individual served by our health and healthcare system. Next slide, please. I'm not going to spend much time on this. I'm only indicating what I previously said, and that is the relationship between what the Leadership Consortium set out as a learning health system on the far left, that is foundational elements of science, informatics, incentives, and culture, and the anchor features of the system at play in the arena of knowledge architecture, the interoperability, the focus of the reward system, and the elements that are especially promoted and how they lead to our shared commitments and the trust framework that they represent. This is a virtuous cycle with a continuous feedback loop. Next slide, please. The shared commitments represent a trust framework for health and healthcare, a pledge of responsibility by stakeholder organizations, a statement of expectations by people and communities, reference points for each stakeholder decision, indices for successful organizational performance, and the North Star for the learning health system. So it is a great privilege for all of us to be here with you to launch the Shared Commitments Initiative. And it's my very great pleasure to now introduce our superb co-chairs leading implementation of these activities will guide us through the remainder of our time together. Peter Margolis is an adjunct professor of pediatrics at Stanford University School of Medicine and emeritus at Cincinnati Children's professor of pediatrics in the James M. Anderson Center for Health Systems Excellence at Cincinnati Children's Hospital Medical Center, where he played a central role in building the center's strategy and approach to health system transformation and provided fundamentally important contributions to the concept and practice of a learning health system. Sean Dowdy is the Chief Value Officer and the Robert D. and Patricia E. Kern Associate Dean for Practice Transformation at the Mayo Clinic, where he leads the strategy and execution for Mayo Clinic quality and affordability, and for Mayo Clinic's learning health system, which is serving as an important model for some of the most exciting outputs from a continuous learning health system. With gratitude to you both and to all the panelists for your leadership. Peter, the floor is yours.
Thank you, Michael. And if you go on to the next slide. The concept of the learning health system, as Michael said, has really been part of our collective conversation for really more than 2 decades. And while many are familiar with it in this on the line today. It may be relatively new to others. And at its core, the learning health system turns every patient encounter into an opportunity for learning. The idea is to take advantage of the wealth of electronic health data that's generated during routine care, not only to inform better decisions for an individual patient, the one in front of us, but also to fuel learning and new knowledge that improves care for all future patients and for the health professionals who are dedicated to achieving the best possible outcomes. A longtime colleague and mentor, Paul Miles, who served as Senior Vice President for Quality of the American Board of Pediatrics, once offered what I hold as a very memorable framing of this idea. He said that your doctor really ought to be able to tell you these are the outcomes you can expect based on the last 1,000 patients like you. And that captures the essence of a system that's built on continuous learning. And I recognize that that may sound somewhat lofty and aspirational, and it is, but it's also achievable. And as Michael said, we have today the tools and technology and expertise that we didn't have 2 decades ago, and it's coming into place to make the vision a reality. And of course, if we intend to build a system, we also have to be clear about what the system is fundamentally trying to accomplish, and that's where the shared commitments come into play. If you go to the next slide, please. So the shared commitments provide clarity about the outcomes that we collectively should expect from our health systems, and they articulate the goals that we should all be striving to achieve. Alignment around shared purpose and a common set of expectations is what builds the will to embed continuous learning throughout the system at every level of scale, whether it's in the relationship between one clinician and one patient, one practice, or one hospital unit, an entire organization, a community, or a health network collaborating across organizations to improve the health of a national population. The shared commitments create a foundation for this kind of transformation. They're intended to serve as a practical framework for building trust and unifying diverse stakeholders. They define what those who interact with the healthcare system should expect and provide direction and accountability for everyone who provides care or seeks to advance knowledge and improvement and treatment. Learning health systems will take different forms in different contexts, and that variability is a strength of the concept. The shared commitments offer a set of core principles that remain constant across settings. They're cross-sector, cross-stakeholder, and cross-setting, and that's by design, creating a kind of common language and a reference point for action. So in this way, they can serve as a catalyst, enabling alignment, building momentum, and allowing every actor in the system to see both their role and the benefits of participating in a system that learns and continuously improves. And so with that, I'll turn it over to Sean, who will share more about how the National Academy of Medicine is hoping to advance this movement.
Thank you, Peter. We've been engaging with and hearing from a wide range of health stakeholders over the last several months. Today is just the beginning of a multi-phased, multi-year initiative that leverages NAM as a neutral convener and the shared commitments as our North Star for the spread and scale of the learning health system approach. Remember that by anchoring stakeholders of the health ecosystem within the learning health system framework, our ultimate goal is to improve patient outcomes and system performance, thereby reestablishing trust in the healthcare system across the entire nation. Uptake of learning health systems is accelerating as many systems are starting to realize the vision of a continuously learning health system and have shown that they can improve health outcomes for patients. And educational programs are underway to help ensure that the new generation of clinicians and scientists are fluent in the creation of learning health systems. We're fortunate to have many examples of learning health systems in action. And to help take this to scale, we envision catalyzing the stakeholder-led movement so that actors throughout the ecosystem can learn from progress across the field and achieve this vision in their own healthcare systems and communities. Next slide. I'll now transition us to our speakers for the day, starting with the opportunity to hear from two key leaders in health system improvement about how the shared commitments show up in their organizational priorities, what's challenging about achieving them, and how they're addressing those challenges, as well as the facilitators that have enabled their successes and the game changers that could unlock new potential to catalyze a culture of learning and improvement. Next slide. First will be Michael Howell, the Chief Health Officer at Google, where he leads the team of health professionals guiding the company to bring the best of Google's technology to the world of health to help everyone, everywhere, find health on their own terms. An expert in the intersection of AI and health, Michael leverages a 30-year career focusing on improving the quality, safety, experience, and value of health and healthcare across health systems and consumer health. Second, we'll hear from Jonathan Perlin, President and CEO of the Joint Commission Enterprise, which includes the Joint Commission and the National Quality Forum, among other arms. At the Joint Commission, he's championed the HELP Agenda, an acronym for focus on health equity, environmental sustainability, learning healthcare and responsible AI, and performance integration of quality priorities into routine operations. Welcome to you all. Thank you for joining us today, and I'll turn the floor over to Dr. Howell.
I want to start by saying thanks to everyone who's joining us on the call for your time and commitment about this. And just to say that I'm deeply grateful to the National Academy for focusing on this work that has been a really big and important part of my own career. And I'm grateful for the opportunity for all of us to recommit to something that's so critical. And I want to say at the outset that it can be hard to hold two things in your mind at the same time. And those two things are that in the certainly in the US and probably globally, healthcare today is the best the world has ever seen. And also, it's stunning how much opportunity for improvement we leave on the table. And so, but between 1995, last millennium, 1995, and 2017, I was either training or taking care of sick people. And if you look at the differences in some areas of care in those, it's startling, right? So when I walked into medical school versus now, if someone showed up to the ER with a heart attack, their chance of dying when I started school, right? I'm old, but I'm not 250 years old. It was double what it is today. One of the worst things that could happen was getting hepatitis C. I mean, I don't know how many people I've dealt with variceal bleeds or sent to transplant, and now we can cure more than 95% of people in just a couple of months. We've seen diseases like Haemophilus B meningitis dramatically decrease over time. All of those things are true. And it is also true that today, 40,000 people globally will die who we already know how to save. We just don't get them the things that they need. It's true that we will kill something on the order of 50 to 100,000 people in US hospitals this year by accidents. And so holding those two, I want to say at the outset that holding those two things in your head at the same time is hard. We are also at a time that is amazingly optimistic because new capabilities are coming onto the field that have never existed in human history before. And it's up to us to figure out how we use those to the benefit of people's health. This year I've had the opportunity to talk to nurses and doctors and folks who have run healthcare on 3 continents. I've gone to a family member's funeral from lung cancer in rural Alabama. And I see things that are both common and unique in all of those aspects. One of the things, though, that is ironic and not in a way that's good is that healthcare generates some of the most data of any industry in the world. And shockingly little of that is used to learn. And when I think about the shared commitments, they are commitments to people who need help, but they are also a commitment to stop throwing away opportunities to learn and to step into new capabilities and new technology that can help us all to get better in ways that we have not been able to achieve technically before. And so I am hopeful and I am grateful to the Academy for helping to focus on the needs of people, the needs of care providers, and the current moment where we may be able to democratize expertise in a way that brings access and expertise to everyone everywhere, not some people sometime. And so thank you for everyone who's joined today and for letting me be a small part of this work.
Great. Thank you, Dr. Howell. I think we'll move next to Dr. Perlin.
Well, good afternoon, everybody. It's a privilege to be with you. And I really appreciate the opening words of my four colleagues who've already spoken. And I couldn't agree more with what Michael just said about the opportunity to tap into the collective memory of healthcare as a learning opportunity to make healthcare better. And as I speak to you this afternoon, I'm actually in a hospital environment. And, I know that all too often when a lab, for example, is ordered, when the result is received, that's the end of it. But if we think of the request for gaining some piece of information, not as something with a fixed start point and end point, but rather a piece of a circle, then we can tap into a collective memory as we feed back not only the actual results of the lab and the context of that, but also the epiphenomenon around that. Why was it ordered? When was it ordered? Where was it ordered? What resources were used to complete that order and the like? And so I really wanted to have the opportunity here, if I can advance these slides, which they're not advancing. There we go. To be able to talk about how over the past really 18 years, my association with the Learning Health System movement at the National Academy and formerly Institute of Medicine, we've been able to create such a mechanism to have that circularity. And really the bottom line up front is that there are three components that are absolutely necessary for that to occur. Beyond the good intentions to take good care of our fellow humans, we need to have intentionally rigorous methods. And a lesson over my experience is that it costs no more to randomly introduce, that is to say, to structural, in a structured manner, introduce a new approach to care than in some non-considered fashion, introducing care without consideration to a design that allows the formal assessment of whether that intervention is working or not. And for the researchers and the audience, step wedge design, cluster randomization, or even a fallback of time series is very fruitful. And I hope to show you some examples of that. And then second, the engagement of colleagues in the learning process creates buy-in for the lessons of that learning process. And that gets at that famous Baylis-Boren conundrum of 17 years from the research to implementation at scale. And the third is that this need not be an isolated endeavor of an individual system, but rather in thinking globally at the public, private, and academic level, the opportunity to create partnerships is really what's the opportunity here. And so I want to return to the original 6 aspirations. Dr. McGinnis provided a broadening of that and give you some examples of some work that supports safety, timeliness, and sepsis prediction and optimization of therapy, effectiveness in terms of reducing MRSA, efficiency in terms of the use of cluster randomized trials, some work that we've done at the Joint Commission in terms of health equity, and patient-centered in terms of maternal and newborn health. So in the following 5 or 6 slides, this is that. It's really interesting. If you look in the late 1990s, early 2000s, you'd see that there were reports frequently of influenza being transmitted from caregivers to patients in bone marrow transplant units and newborn intensive care units. When you actually serotyped the type of influenza, you could prove that it was nosocomial transmission from those caregivers. And so one of the things that personally had the opportunity to support was that Joint Commission and Past Life actually support caregiver immunization for influenza. And you can see as the rates went up, what's not shown here is that there was never any cluster randomized trial on this because it would have been unethical. But what there is obviously a correlation between the rates of caregiver vaccination and the presence of those requirements, which prior to my time and my leadership role here currently was terminated because it was, quote, topped out. But you can see that the rates of vaccination dropped off. So this is simply a time series approach. We're going to show you a much more applied approach. At the very beginning of this movement toward learning healthcare, one of the most illustrious proponents was the late John Heisenberg. John would ask, what would a Martian think? Meaning, what would a totally naive observer think? The graph in the top left is a 24-hour clock about showing when sepsis was identified across a number of hospitals. And the darker the color, the onset, the frequency of the onset of sepsis. And that Martian would then think that sepsis occurs at shift change in major hospitals on the 12th and 24th hour, which of course it doesn't. Using machine learning to spot sepsis, you can actually see that it's distributed around the clock. Now, why is that important? It's critically important for one reason. That is, every hour of delayed diagnosis in sepsis increases mortality between 4 and 7%. And so if you can turn the clock back, 2 hours, 3 hours, 4 hours, 5 hours, then there's an incredible survival advantage. We were able to do that in this work that was fundamentally inspired by the Learning Health System collaborations at the National Academy of Medicine. Across 63,000 beds in my former healthcare organization. It's nice that we were recognized, ironically, with the Eisenberg Safety and Quality Award for national level innovation. Over the course of the succeeding 5 years, this saved against previously demonstrated benchmark levels of performance an additional 8,000 individuals. I like to visualize it like this cruise ship, 8,000 individuals who saw in a new year, celebrate an anniversary, welcome a child or a grandchild, or the like. I want to take you back to my first encounter at the Learning Health System, and I had the opportunity to present some work that I'd done in the VA and brought over to the large health system that I was a part of, HCA Healthcare. And we had been screening patients for MRSA, and if positive, isolated them. Rich Blatt from Harvard and John Jernigan from CDC came over and said, "That's nice work, but how do you know that's best?" So what do you mean? He goes, "Well, if you screen and then isolate, by definition, you've lost a day. If you screen, isolate, and treat, maybe that's better. Maybe we shouldn't be screening at all. Maybe we should be universally decolonizing with a sponge bath of the skin with chlorhexidine and nasal mupirocin. So, and if we use the technique of a cluster randomized trial that is assigning hospitals to one of the three strategies, then we can actually definitively prove what's best." Well, it turns out that the answer wasn't subtle. In fact, above all known best practices, the introduction of universal decolonization for patients in intensive care reduced MRSA by 37% and all bloodstream infections in the ICU by 51%. And obviously, it was a major paper in the New England Journal. It was cited over 2,000 studies. But the part of the headline that's so important here is that it didn't take one hospital 64 years to achieve this data. It took 43 hospitals 18 months. And that to me was a major win. Well, it led to a second, and this gets to the efficiency of research in this instance, or efficient healthcare, which requires research and learning, which was people began to extrapolate to the general medical and surgical unit, saying that if it works in the ICU, we should do it there. Well, not so fast. In this study, 53 hospitals, 670,000 patients, what would have taken one hospital 93 years took only 21 months. And the answer was, it reduces infections by 37% for patients with central lines and devices. It doesn't really work for other patients. And then a third study, because high-level drug resistance represents an existential threat to mankind per CDC. This was a 1.2 million patient, 123 hospital non-inferiority trial, also set into a cluster randomized matrix. And it was to do a sort of head-to-head comparison of upiricin, antibiotic, against which there's little but theoretical resistance, versus iodophor, a chemical, which would likely develop little resistance. And sadly, the iodophor did not prove effective in this trial, but it would have been nice. But that answer, which was 123 hospitals, 1.2 million patients, was actually achieved also in a matter of months. The Joint Commission, we set up to measure the impact of an equity standard, and we had a sample of those hospitals that were surveyed versus those that weren't under the new standard. And it's really remarkable, and you can see a list on the left, the sorts of things that were the focus areas of the different organizations. There was a statistically significant difference in terms of the cost of care, the utilization of resources, and trends toward better health outcomes, improved community health status. It was not an ideal sort of trial setup, but let me show you one now, speaking to patient-centered. This is also work inspired by the Learning Health System and building on the approach to study design and improvement that was demonstrated with reduced MRSA. So against the backdrop of all of evolution, it turns out that over the last 30 to 40 years or so, we've reduced average gestational age by 10 days. Now, that might not be much, but it begs the question, using bad outcomes and going to the newborn intensive care as a proxy for making a difference, is there a difference between 37, 38, and 39 weeks? And you can see here, there's roughly a fourfold increase in bad things leading to going to the newborn intensive care unit. Well, having created that data, one needed to be able to say, okay, what are you going to do about it? So we did another three-arm comparative effectiveness trial, cluster randomized by intervention, education plus sanction for repeated offense, or hospital identifying a policy against early elective delivery. And the one that worked was the hard stop, as it's known, which has become a standard of practice. Again, validated by a couple of studies that used improvement opportunities in a formal research matrix. And so let me conclude with this, whether it's saving lives in the instance of sepsis, whether it's improving health equity, whether it's the efficiency of proving that operational improvements make a difference, or whether it's preventing a completely preventable adverse health outcomes in neonates. Intentionality in creating a credible research design for improvement activities helps us really know what works and what doesn't with the formality of science. And if one engages colleagues broadly, you help to create the conditions in which a healthcare organization can become a learning healthcare organization and transcend the diffusion gap of 17 years that's too often been the characteristic of much improvement research. In point of fact, for the reduced MRSA, the research was translated into 100% diffusion within 2 quarters in our organization. And in fact, more broadly with partnering organizations. And that's an incredible last point, because that none of this would have been done by one organization alone. CDC, academic institutions, and community hospitals came together using the platform that the National Academy of Medicine put forward. There are too many collaborators to name, in particular, those in red: Steve Clark, Trudy Goheel, Susan Wong, John Jernigan, Rich Platt, Russ Poland, Ken Sands. All deserve credit, but a very special credit to Dr. Michael McGinnis for his leadership in this collaboration. I thank you for the privilege of being a part of this over the years, and I look forward to continuing to learn with you.
Michael and John, thank you for those thoughtful overviews of the state of our healthcare system, how far we've come, and the huge opportunities we have in front of us. We now turn to our reactor panel. Each a respected and forward-thinking leader in their own right to offer reflections on the presentations we've just heard. We've invited them to share their perspectives on what resonates most and what they see as the most exciting opportunities for the shared commitments to serve as common ground and a foundation for rebuilding trust as we advance the learning health system. First, we'll hear from Suzanne Miyamoto, the CEO of the American Academy of Nursing. With nearly 2 decades of policy, advocacy, and leadership experience, Dr. Miyamoto directs the internal operations to help the organization achieve its mission, vision, and strategic plan, and she is highly regarded for expertise in healthcare and education policy, as well as her leadership and successful development of advocacy-based coalitions. Then we'll hear from Donna Cryer, the foundation of Global Liver Institute, a patient-driven nonprofit advocacy organization. Mrs. Cryer has raised more than $20 million for liver health initiatives directly and uses her business and legal acumen to de-risk investment in the field by convening and facilitating more than 200 organizations toward collaborative multi-stakeholder agenda setting in action, building strategic approaches to therapeutic and diagnostic innovation, regulation, adoption, and payment structures for best practices to optimize access and outcomes. Suzanne?
Well, thank you so much for the opportunity to present today and share a little bit of reactions to a fantastic discussion around the learning health system. I too, just like Dr. Perlin, would like to thank the National Academy of Medicine and the Leadership Consortium's commitment to the learning health system. As you have heard, the current healthcare system has the opportunity, but is also challenged to think creatively while grounding itself in quality patient outcomes. The pressures the healthcare systems, hospitals, clinics, and clinicians will face as a result of the vastly changing landscape in policy and technology requires now, more than ever, the shared commitments and foundational elements of the learning health system. Consider first the policy changes that will soon take place. As you know, earlier this year, the budget reconciliation package made sweeping changes and drastic cuts to the Medicaid program. Released just last week, Kaiser Family Foundation, or KFF's 25th annual Medicaid budget survey, already pointed to the pressure states will feel as they prepare for the $911 billion cut to the program in 2026. The KFF survey noted that Medicaid enrollment fell 7.6% in fiscal year 2025, and that is expected to be largely flat in fiscal year 2026. This is also conflated with the fact that the total Medicare spending grew by 8.6% in fiscal year 2025 and expected to grow 7.9% next year. This is currently strained budgets, and they're having a difficulty at the state level absorbing and considering how they'll offset these reductions as H.R. 1 work requirements come into place and the financial restrictions come into play, in addition to what we already know as the greater healthcare needs of Medicaid enrollees, as well as those clinician rates that are increasing. Moreover, we must consider the financial drivers and downstream effects of the policy that still requires congressional action before the end of the year. If the Affordable Care Act subsidies are not addressed, which, as you know, was a significant driver of the government shutdown discussions, millions of individuals and families will see higher premiums in 2026 or lose their coverage altogether. The Center on Budget and Policy Priorities noted that 22 million people will face higher costs or lose coverage entirely, and around 7.3 million could lose their subsidized coverage and become uninsured. At the same time, as was mentioned by Dr. McGinnis, digital technology is creating new opportunities for the healthcare system. Artificial intelligence, of course, has exploded, and the interest in supporting improvements to healthcare, and the system come with opportunity, but also great risk. AI can certainly reduce the burdens of administrative and documentation tasks for clinicians and allow them to focus on patient care. But the critical thinking and the clinical judgment of clinicians cannot be replaced by AI, nor can it replace the human connection that is so central to the clinician-patient relationship, which is vital to building trust. And trust is so critical in that learning health system. From a risk perspective, data protection and privacy concerns must be considered as we look to address policy and regulation changes. And taking into consideration, we must look at the important ethical and equity considerations. So there's so much between policy and the explosion of digital health components and artificial intelligence that challenges yet creates opportunity for the learning health system. And yet I think this is where the shared commitments come into play. This is what is so exciting about the work and how it needs to be moved forward, because they have the ability to meet these challenges head on. And one of the areas that I think is absolutely foundational for that learning health system to thrive is the commitment to being adaptive. We must learn, we must try new models of care, we must marry our approaches, and all of them must be built on that framework of trust, trusting our colleagues within the clinician environment, those that serve in our leadership positions within the institutions, but also across the healthcare industry. In terms of marrying approaches, innovative models of care can certainly use technology, incorporate different staffing mix, and address costs when they're looking at the full healthcare team. And the full healthcare team is needed to solve these problems. Over time, models of care have been lauded as evidence-based. They have been multidimensional strategies that improve quality and reduce cost. However, at the same time, some of these models that have come forward have been limited by their ability to scale or spread more widely and be adopted. And this again relates back to some of those resource challenges and some of the reimbursement models that we have. And yet the learning healthcare system is a place and the model that can help amplify and spread these new models of care when we are adaptive and looking how we can use new innovations within the system. I think, for example, about the strides that the nursing segment and nursing leaders have made to consider how virtual nursing models of care can better improve patient outcomes, support their colleagues, and create opportunities for improvements. As I look to the future and think about the demand for digital and artificial intelligence, think about the demand that will be needed both within the health system and outside of it as we think about digital and artificial health literacy. This is where nurses and other clinicians who have been the cornerstone of patient education can support a health system and the patients they serve. It is the researchers, it is the nurses, it is the clinicians, it is the system overall, it is the leaders in the information and technology space that come together in the learning health system to move forward. I see this as a movement, a real movement to think about healthcare as that team-based approach built on that foundation of trust. And looking at the future that is ahead of us, yes, there are many challenges. There are many policy that will come into place that will, again, have downstream effects on the health system and how we move forward. But I think the adaptability and the opportunity that lies forward is really grounded in the learning health system. So I thank you for the opportunity to share some reactions about both the challenges we face, but the opportunities that are coming forward and will remain there with the learning health system.
Thank you, Suzanne. I'll turn it over to Donna next.
Hello, everyone. I'm very honored to be part of the launch of this work on shared commitments and learning health systems. One of the things as a patient leader, having been involved in learning health system work for many years, is the humility that it takes to admit that we haven't had a learning health system to date. And how surprising that is for most patients who think that their contributions from every visit are put together in unique forms to learn. And to answer that question that Peter started us off with, that they should be able to tell you what outcomes could be predicted based on 1,000 patients like the patient before them. That's what patients want, and that's what's so exciting about what we aim to do today and moving forward. I would be remiss as a leader in hepatology if I did not take up Dr. Howell's lift about hepatitis C, and perhaps use the first of my 2 stories in this short time to contrast the launch of the hepatitis C cure. It is a cure. That's amazing. I've never seen that on FDA slides before. And yet, because it was not developed and launched in collaboration with the community, so the point of engagement, as we talk about as part of the model, it did not achieve all it could have achieved in that early time. We're now bringing this apart. I applaud the leadership that Francis Collins has newly brought to re-energize the work that the community is now doing together around hepatitis C, so that we're not just focusing on price, but value, and most importantly, on the value of people being cured. And connecting it with community organizations who are in touch with people every day in that last mile, that last foot, that last inch, which is necessary to connect and even as the most innovative medication to the person to make access truly manifest. So I would contrast that with our experience in, whether you want to call it fatty liver disease or NASH or MASH, MASH, metabolic associated steatopic liver disease. When I look back at my role as founder and as CEO of the Global Liver Institute, if I ask myself the same question, which is my favorite question to ask when I'm changing a department or vision or new to a space or a company, and I ask someone, what is your real job? And I asked myself, what was your real job over those past 10 years? It really was creating safe spaces for trust to happen. And not just for patients, but for physicians from different specialties who had not worked together before, for medical societies who had not welcomed each other into their medical meetings, for industry partners, and yes, for investors from other spaces to view research in hepatology and solving the problems that matter to liver patients and liver researchers as important and worthy of their investment. And so we saw the power of creating safe spaces, of having enough trust to say difficult things, to say things that when in environments with diverse stakeholder groups would launch the need for non-invasive technologies, not after a cure is approved, but a decade before, seeing into the future and working together and seeing what would the barriers be to this being adopted fully and pulled through to adoption. Having invited the members of the Obesity Society, as well as the cardiologists and endocrinologists and hepatologists, family medical medicine practitioners to the table from the beginning to create this field that is now so vibrant. The key refrain I always hear when patient engagement is brought up is that, oh, it'll take too much time. We proved otherwise. We proved that we were swiftly able to create a field, approve a drug, get it into adoption with the right diagnostics, and changing people's lives because we work together, because we engaged with transparency and candor from the beginning. I also saw it, and I'll just quickly mention this because it filled me with so much glee, and I feel we need a little glee these days in medicine and in healthcare. I freshly come from the liver meeting in Washington D.C. Was sitting with a researcher that I've worked with on AI and large language models, and introduced him to several of my top patient advocates who have come through our Advanced Advocacy Academy. And because of the strides that we have made with the Medical Society, we're now having posters and presentations and fully integrated into the meeting in the short, I think short at this point, course of a decade. And the impact that it was making in AI, this real world efforts that we had done to improve engagement and collaboration, was that the sources of data that this researcher was pulling in for his projects in AI were already infused with patient engagement. And so we had improved the quality of the data at every source point, whether those were the guidelines where patients now sit, the literature where patients are now publishers, the EHRs where as a former HIT policy committee member, we have made our mark there, and are still working with them and willing to collaborate to find those hidden parts of data that are in Facebook, on peer conversations, on chats, and can really truly inform AI so that we can get to the most comprehensive as well as the most accurate and efficient outcomes. And so I look forward to the work of this learning health system shared commitment work. And I see so many opportunities already happening that make this work an exciting field to flourish and to be. Thank you.
Okay, Donna and Suzanne, thank you very much. And really thank you to all the speakers for your commitment to the learning health system and the shared commitments in general. So I'll now turn it over to Peter to make some final remarks to close us out.
Thanks, Sean. So we've heard a lot today. We heard about the need to stop throwing away ways to learn. We heard about the importance of rigor and engagement and partnership in building a kind of platform to grow learning at a pace that we expect. We heard about the need for a movement, and we heard about the importance of humility and recognizing that everyone it needs to be part of this work. Our belief is that we're positioned at this time where the goals of the learning health system are within reach if we can build the will to make it happen. And realizing that is going to take leadership, not only from organizational leaders, but from everyone. People at every level who are prepared to inspire and lead change from our own roles and contexts and communities. So as we close today, if you can go to the next slide, we want you all to we want to encourage everyone that really this is the beginning of an ongoing conversation, and to continue that conversation, we invite you to take our survey, to hear more from you by scanning the QR code that's on the screen. We'll also put a survey link in the chat. We'd like to hear about what resonated, what we can do to overcome some of the policy and technical and social barriers to implementing the shared commitments in order to help you achieve this shared vision in your role and with your organizations. We're very pleased to share our recent article that was in the New England Journal that was released in June that outlines the vision for addressing these longstanding barriers and for building the will and capacity to advance the shared commitments. And we invite everybody to visit the National Academy's website to sign up for our mailing list and stay connected to the National Academy's work, and to be part of this multi-organizational movement to embed the learning health system into our organizations to achieve better health outcomes. We hope this will keep you abreast of what's going on and offer ways for you to hear about other opportunities to get engaged. So on behalf of Dr. McGinnis, the National Academy staff who really worked tirelessly, we want to thank all the speakers and reactors for their leadership and their guidance. Thanks to everybody for joining today and for being part of the group of innovative, dynamic leaders who are helping to shape and define this movement to advance improvements for our healthcare system, and most importantly, for the health and well-being of people that our health systems are meant to serve. So thanks very much for participating, and we look forward to hearing from everyone.